I wear several hats. I am the Chief Executive Officer of a 501c3 nonprofit that actually has an APA-accredited training program for clinicians, and that's one thing I think is very important in this. As we all know, virtual reality is really just a tool, and having the good clinical skills and the good clinical judgment is one of the things that sets it apart and makes it important for our patients. So I started using virtual reality 21 years ago. I had one of the first PC-based virtual reality systems for behavioral health care. And this is one of my very first patients, Kevin. He's been one of my best teachers, and all my patients since have been. So Kevin sat in the head mount. He looked around. He controlled what he saw in the virtual reality world. And so I didn't have to take him to the airport or on an airplane flight to get him over his fear of flying. He reached his goal of going to the East Coast for his high school reunion. And he called me 3 years later and said, the skill sets you taught me in that virtual world, I actually used to also get over my fear of heights. So virtual reality isn't just about throwing the patient in the world. It's about putting the patient into the world after you've taught them skill sets, having them practice those skill sets and become more self-confident, create more efficacy and self-efficacy, and then be able to translate that newfound behavior into the real-world setting. I know it's important to have patient stories, and again, they are my greatest teachers, and though I wear many hats, one of the ones I'm most proud of is being a clinician. I'm licensed in both Belgium and in the US. Used to be licensed in Switzerland. But I know it's also important for the field to move forward to run randomized controlled clinical trials. So when I first got the system, I did the first randomized controlled clinical trial using virtual reality for behavioral health care. I had 3 groups. One group got traditional therapy, one group got virtual reality, and one group got virtual reality plus biofeedback. And what did we find? The group that got virtual reality plus biofeedback not only did better in the beginning, but after 3 years had no recidivism, no relapse. So providing those physiological signals, teaching people what they feel like and what their physiology looks like when they're stressed, when they're relaxed, and teaching them to use that as a control mechanism in that phobic situation really empowers them, educates them, and allows them to have long-term gains. So this is what we show them in the clinic. We show them what their physiology looks like, and then we teach them to slow down here on the right their physiology so that they can slow that heart rate, their respiration rate. Then we teach them how to control their cognitions. The first head mount was created in 1968, so almost 50 years ago, at MIT by Ivan Sutherland. So it's not new, but the technology keeps getting better and better so that we can disseminate more quickly, more easily. We've been treating patients for 21 years at Virtual Reality Medical Center. We have clinics in Asia, in Europe, and in the US. We've formally formed a corporation in 2001. And one of the things we're most proud of is in the very beginning, when we first started this in 1996, we had everybody work as a team. So my autistic patient or my phobic patient or my peak performer athlete or a first responder in the military would come in, they would sit with my clinicians, my graphic artists, and my computer technicians, and they would work together to know what is the best world, what are the cues that are important for that person, not what's pretty and has good pixels, but what is really important to elicit that anxiety or get that proper training. We've developed over 200 VR, AR softwares in-house, and we have clinically validated protocols. I've published some of my protocols, and they're in 7 different languages. So I think it's important to disseminate this and disseminate it, again, in clinically validated ways. I also, again, have an APA-accredited training program. I've done myself 10,000 VR sessions, so I've done a lot of VR sessions. And again, I get something new from each patient I see. I'm able to elicit more from them. They also help me write my clinical protocols in my books I've published. We've done some other big studies. These are some of our big studies done by the military funding, EU funding, and funding also in China. And we've taught people like teen drivers how to drive in virtual reality, because as you know, a teen driver is very good when everything's going perfect. But when somebody runs out in front of them, when a car cuts them off, they're not able to respond because they're a novice. So you put them in the virtual reality, you teach them in that safe environment, and they can translate those skill sets into the real world setting. Why is VR superior? A lot of us do not have good imaginal abilities. So if I say, you come into my office, you have a fear of snakes, and I say, okay, imagine a snake. The first thing you're gonna do is not imagine that snake, because you want to cognitively avoid what you're afraid of. So in VR, as one of my patients said, it's in your face. Sure, you can close your eyes, but you can still hear it. In many cases, you can feel it, the vibrations, the tactile stimulation. So virtual reality stimulates your senses. You know, a part of you knows that you're in my office still with me, but a lot of you gets immersed or present in that world. You're able to feel those sensations, but you push the envelope, because that part of your brain that knows you're still in the office with me allows you to go further and go faster. So it's more effective, more efficient in many cases. It's also in many cases more safe. And it's a lot better than this. This is Harry. Harry used to live in our lab. And Harry is a Chilean rose-haired tarantula. But Harry needed fed and his cage needed cleaned. So the final tipping point was when one of my interns became allergic to Harry. They have these tiny little hairs that break off and go down in your lungs. So we found Harry a good home, and we got virtual reality for fear of spiders. Virtual reality also has problems, though. Some people suffer from what we call simulator sickness or cyber sickness, similar to real-world motion sickness in airplanes or in cars, a little bit different. We used to have about a 2% rate of cyber sickness. Now we have about a 10% rate. So it's kind of interesting, as the technology has gotten better, we are seeing actually more cyber sickness with people. So we need to solve that problem. A lot of my patients I now have to pre-treat with anti-motion sickness drugs before they go into the virtual reality. It doesn't take away from the clinical efficacy, but is a problem because they have to have somebody drive them to and from the sessions now. Stephanie was an 18-year-old on her way to college from San Diego to Denver, and in the blink of an eye, her life changed. A teen driver cut her off, slammed into her SUV. She rolled over several times and woke up in the hospital. She had been rescued from the wreckage by the jaws of life. Took several operations to get her over her physical injuries, and then she had to start dealing with the grief of her father being killed instantly in that car accident. We saw her 2 years after the accident. She had dealt with the grief. She was still in physical rehabilitation, but she wanted to be independent again. Her mother had to drive her everywhere she went, and she wanted to be able to drive herself at least to her physical therapy appointments. But virtual reality allowed us to put her back in those driving situations without re-traumatizing her. I monitored her physiology in real time, so I went at her individual pace. I put her through all the virtual environments. She, the first session, only sat and cried and held the steering wheel. She couldn't do anything else. But we slowly and systematically got her to go through those driving situations. She was able to translate those skills in between sessions and go into real-world driving situations. And she moved out, got her own condo, and started driving herself, as she said, anytime, anywhere she wanted. We've also used virtual reality a lot for post-traumatic stress due to recent wars, so we can use it for wartime events. We were funded by the Office of Naval Research to hold focus groups from people coming back from Iraq and Afghanistan, then to design, develop, pilot test, and then hold the first randomized controlled clinical trial for using virtual reality for PTSD treatment. We did this in the San Diego area. We found that people that got traditional treatment, 20% dropped out and only 40% got better. But with the virtual reality, we had an 80% success rate and no one dropped out. It was less stigmatizing to the guys. We find when we deploy the systems, so we have our systems in several VA hospitals, in Croatia, in Poland, and we sent systems in theater with the troops. This is Commander McClay. we find we have better success rates. So when you treat a patient near when they have acute stress disorder or have just started getting post-traumatic stress, you have a better chance to intervene early and have your success rates go up. Now, I talk not only from a clinician perspective, but from a patient perspective. This is me, and this is me getting my blood drawn, which for many of you is not a big deal. But I used to faint when I got my blood drawn or saw a needle. And when I had to have my annual physical, it would be weeks. I would be terrified, staying up nights, worrying about it, and it was a big ordeal for me. I may have never gotten treatment for this. There was no virtual world at the time, but I had a patient call me and she said, I had a stroke in my 30s. I need to go for an annual checkup, but I cannot think of going and having a needle poke again. Can you help me? And I said, geez Louise, I'm gonna faint before I get through this session. So I said, you can come in 2 weeks. I don't have an appointment before that. And so for the next 2 weeks, every day I did my biofeedback. I did what's called applied tension to make your blood pressure actually go up some. And I worked with phlebotomy films, so watching blood draws, because we had no virtual reality at the time. Then I had my programmers go to scripts with me, and they followed me around, and I turned in my orders, and I got my blood drawn, and we did the whole 9 yards, and I treated the patient with our first virtual world for blood draws. So I have her to thank for me now not minding my annual physicals. We were funded by the National Institutes of Health, National Institute on Drug Abuse, to create 7 virtual reality worlds and clinically validate those. We made them in ISO 13485 medical grade facilities. I think this is very important to do with some of these more medically grade worlds. We've tested those in both Europe and in Mexico, and they're in use in Asia. This is one of our latest studies. We've done over 1,000 patients using the virtual reality in the hospital setting, and we used it in endoscopy on 115 patients. Some of them got virtual reality, half of them got virtual reality, half did not. The group that got virtual reality had lower pain and anxiety scores during the procedure. We only had to use local anesthesia instead of general anesthesia, so less cost, less complications, and less recovery time. The doctors, amazingly, also had less stress. So the doctors said they had less stress, and the operations took, on average, 2 minutes less when the patient was in the virtual reality. We've also used it in post-procedure. So this is in a cardiac ward. You can use it in this setting so that their acute pain does not lead to chronic pain. We've done a lot with chronic pain, both in PC-based systems as well as in mobile systems. And if we can treat the patient quickly and when it's still in the acute phases, sometimes they will not develop the chronic pain. Sometimes they will, and we have solutions for that. In the last few years, with some of the new technologies, we've been able to take the show on the road. So we can treat patients with sports watches or other mobile sensors, so they still have that objective data. iPads and virtual reality that actually the sensor syncs with the virtual reality, so their heart rate, their respiration can actually control parts of the virtual reality world, which is very powerful for the patients. And then we can, of course, use the Samsung or the Google or the other monitors. This is one of my patients, and I really love to tell her story. And I spoke last week at a digital medicine conference in La Jolla, and Eric Topol flew her down from Palo Alto to speak to the clinicians and the technologists in the audience so she could tell her side, because you only tell your story the best, right? I can tell it, but she tells it the best. But her mother was living in Singapore at the time and put out a query on the web and said, my daughter just finished her graduate degree and she ran out in the street last week in the middle of traffic to get away from a pigeon. Can anyone help me? And the answer came back, have you tried virtual reality? So Nia's mother got in touch with me and said, can you help my daughter? I said, we no longer have our Palo Alto clinic, but if she can come to San Diego, I will try my very best. So Nia put her life on hold, came to San Diego. I saw her twice a week, or twice a day for a week. And by the end of that, she was laughing while she was in the virtual reality, surrounded by birds, and able to go to work, go to class, go on vacation where there were birds before she had avoided these situations. So it was very powerful. Last week, hearing her tell about it, it just amazed me. The letters I've gotten from her mother saying the difference she's seen in her child have just been so rewarding. Nothing else is worth something like that. Again, just to end, we've done a lot with prevention. I was funded for 3 years by the European Commission to work with nurses and teachers that were at risk for burnout, and we taught them stress management skills. So moving the model so it's more about health and well-being and prevention instead of always waiting till somebody is sick and having the disease model and doing treatment. In this case, we've also used it with first responders, both emergency room physicians in Jacksonville, Florida, as well as in Hungary, in US, in Poland, with combat medics and other medical personnel. And we can train them in the virtual reality. We have score sheets. Then we transfer and test them in the real world setting with real lifelike dynamic wounds. And we can see if those skills have been transferred over. If they haven't, we can train them more in the virtual reality. We can also do booster sessions in the virtual reality. So again, virtual reality is powerful for training and therapy. These are just a few of the examples I've had the privilege to work with over the last 21 years. Thank you.